It really is a pleasure to be here. It's particularly a pleasure just looking out of this window and seeing green and seeing leaves. We won't see those in New Hampshire for another month, so, and we've had a brutal winter. I understand it's been a little chilly here too, but anyway, I'm happy to get a little taste of spring and to be here. And particularly to have the opportunity to talk to you about this topic. By the way, there are 4 busloads of adult health care providers that are coming behind me that I arranged to come here to begin to receive your pediatric patients that you're hoping to transition. They'll be arriving sometime over the weekend, but anyway, I thought you'd appreciate that. I just want to check and see how many of you are still seeing your pediatrician. Is anybody? No. And so you've all transitioned. You've all gone through this process. How many of you had it as a kind of a mindful, planned process? Nobody. I'm not surprised. I didn't either. I think that's part of the reason we're here. And it's particularly about children with special health care needs whose well-being is really in the balance in terms of how we handle this. And I think as a pediatrician, it began to dawn on me that what was the point of 18 or 20 or 16 or 22 years of the highest quality care I could provide if there was going to be nothing to follow that. And I certainly wasn't going to stay involved with my patients, or at least very many of them, until they were my age. So I felt that this really is a critical, and it's an extension of your efforts around medical home. Because what's the point of a really wonderful medical home if there isn't a new medical home for young adults to go to? And I don't have anything to disclose in regard to this presentation. And I'd like to introduce you to Sarah. Sarah's my eldest daughter. She turned 30 last summer. And my oldest child. I have another daughter and a son. She has Down syndrome, as you can probably discern. And she had a very complicated early life, as some children with Down syndrome do. She had a complete AV canal that was repaired when she was 6 months old. She had pneumococcal meningitis when she was 4 months old. That was my first experience as a pediatrician dad of a child with a fever. It wasn't an ear infection, as it turned out. She had duodenal atresia repaired when she was 1 day old. But following those events, she maintained a pretty healthy life. She had some ear infections. She had, just odds and ends. She lost a pierced ear into her earlobe and had to have a little anesthesia in order for the ENT doc to fish that out. But the night before, we were flying to Arizona to visit my family. In any event, not a whole lot of things went on until about 5 years ago when she developed bacterial endocarditis. She and I had the flu, what seemed to be the flu, about the same time, around Christmas time. I got better in 3 or 4 days, and her flu seemed to linger on for another 2 or 3 or 4 days until we got worried about what was going on. And her echocardiogram showed that she had quite a bit of things going on inside her heart. It was an invasive organism. She had to have a mitral valve replacement and a pacemaker, which she still has. And she has to continue on Coumadin. But she was hospitalized for a month at Dartmouth when this happened. And it was her first hospitalization as a young adult. And though we transitioned her primary care to adult providers in our community, we hadn't really paid a lot of attention to other specialties and so on. So her mother and I found ourselves in the hospital with adult cardiology teams. She had some GI problems that confused the adult GI folks when they looked at her anatomy on both endoscopically and on contrast studies. They couldn't figure it out. Her bowel surgery had been done before the era of electronic health records. So the records were archived somewhere. someone finally dug them up and found a little sketch of the repair of her duodenum at 1 day of age. And it helped these adult cardiologists understand duodenal atresia, which they didn't see a lot of, and help Sarah. Fortunately, Dartmouth has an adult congenital heart disease program, and her pediatric cardiologist is one of 2 physicians, the other is an adult cardiologist, who manage that program. So they were able to make rounds together. But just about every specialty, infectious disease, pain management, were people who were unfamiliar with Down syndrome, unfamiliar with the complications of her early childhood and the consequences of them. And we were constantly troubleshooting around this. Fortunately, things turned out all right, and she's continued to do well. This is a hike in Colorado 2 years ago, so she's up and around and managing well. But it was, I think, the lesson, perhaps, that even if you're considered to be a God transition guru of some sort, it's like the shoemaker's children. You don't get it all handled the way you might have or should have in a planful way. So first they make you button your own shirt, then they make you tie your own shoes. You got to ask yourself, where's this all heading? And I think that's really the message that I'm trying to convey, that we and our families that we work with are asking one another, where is this all heading? And we're doing that at an early enough age that we have time to plan, and that we have time to prepare, and that we have time for those busloads of adult healthcare providers to arrive to take the patients. And as you can guess, I'm anticipating that when we have questions and answers, somebody is going to say, there are no adult providers around. And we'll have a little bit of that conversation. So I'm going to talk a little bit about the case for improving transitions from pediatric to adult care. You know, there really isn't any need to make this case anymore. It's so clear. Whether you look at surveys with families, or you survey pediatricians, or you survey adult health care providers, this is a problem. And it's a public health problem. It's an individual health problem. I will run through some of that evidence just because that's what you do in a presentation like this. But we don't need any more research about whether or not this is an issue. It's well established. I'll talk to you about the clinical report on healthcare transition. How many of you are familiar with that report, the AAP's clinical report? It appeared in Pediatrics in July 2011. I had the privilege of being a lead author on it, but it was actually authored by a writing group that included adult providers, families, some policymakers, some payers, as well as pediatricians. So my job was to try to herd all those people together in a room and agree on, for example, what age do we start? Or what age do we transfer care to adult providers? The Academy likes their policy statements to be in concrete language. It translates into electronic health record utilization better if things are exact rather than saying, you know, more vague things. So we were obligated to be specific, and we did discuss those things at length. I'll talk a little bit about quality improvement strategy and transition learning collaboratives, where we piloted some of these tools developed by God Transition, and sort of look at what next steps might be. So every year, 500,000 youth in this country with special health care needs become young adults, graduate into the adult health care system. That's a lot of youth, and we need a solution that is broader than transition clinics at children's hospitals. They're wonderful, wonderful things for youth with complex needs, but they're going to have, you know, 100, 200, 300 patients maybe. They're not going to address a 500,000 youth every year. So we need to have this embedded in our healthcare system. Some are able to independently negotiate this, as most of us did at one time or another, but they're particularly children with more complex health care needs are going to need help. Their families are going to need help. The U.S. Maternal and Child Health Bureau surveys these families and other families whose kids don't have special health care needs every 5 years. And a subset of those questions are the children that we're focusing on somewhat today. And this survey is used to sort of inform progress with Maternal and Child Health Bureau's goals. And some of these goals you'll be familiar with. You've probably worked on them here. I know you've worked on medical home. And we're doing pretty well with things like early screening and with partnering and shared decision-making, with family-centered care. But transition has remained at the bottom of the list. And on the last survey, and in all of the surveys, less than half of families say they're getting help or the help they need with this transition. There's a quirk in the wording of these surveys, however, that tells me that this 40% is actually a major overestimate. And it has a follow-up question about whether a discussion would have been helpful. And if families don't even really know this is a problem, they often say no to that question, that a follow-up discussion wouldn't be helpful or wasn't needed. And then they're not included in the calculation of the percentage of families who didn't get help with their transition. And if you revise the analysis so that those families aren't thrown out, then the success for families becomes 13%. And when we figured this out a couple of years ago, it finally made more sense to me, because in all of the going around and talking to audiences like you and talking with families, I thought that 40% seemed like a high number. Because everywhere I went, people were saying, we pediatricians were saying, we don't really know what to do with this. We don't know where to send these kids. We don't have a transition policy in our office. We don't, all the things that said to me, we're not doing this with 40% of families. We're doing it with fewer than that, probably. And we've got to, see that improve. If you drill into the data on the survey, you find that those least likely to get help with transition are likely to be male. They're likely not to speak English in their home. They'll have family incomes below the 400% of poverty line. And these are all factors that raise the stakes, probably reduce that 13% to practically zero. They have emotional, behavioral, or developmental conditions. They have conditions that impact daily activities. They don't have a medical home, and they don't have insurance. The reasons for this are that youth and families are, the youth in particular, have little or no experience with taking responsibility for their health care decisions. Their mom or dad or somebody else, an adult, has handled those decisions and handled those interactions with doctors for their entire life. And they and their families have reticence in leaving their pediatric providers. I mean, you all, I'm sure, who provide pediatric care are familiar with that scenario. They have difficulty identifying adult providers. They, like us, aren't sure where to turn in the adult healthcare community, and they have fear of not knowing what to expect with a new provider. It's why leave what you know and have known for years for what you don't know? And at least until recently, there was a generalized lack of insurance continuity. And fortunately, that's improved somewhat in most states with the Affordable Care Act. Pediatric providers, they too find a lack of available adult doctors, a lack of payment for transition services. These are those meta services that aren't necessarily provided around an encounter, but are occurring in the sort of care coordination space. Now, I know you've had some success here in Tennessee with care coordination services. I learned this over dinner last night, and codes being utilizable and billable, though I know there are also a different process than some of your billing folks are used to using in terms of accounting for the work that gets done. But planning for transition falls into this care coordination space quite completely. There's a lack of skills in planning, including the value of an early start, and a lack of knowledge about community resources, particularly those that adults are going to need to utilize. Pediatricians tend to know a lot about the school system and the early intervention program and some of the other services, but in the kind of pediatric framework, and they're less likely to know about the adult developmental disability system, for example, or about waiver services or dually eligible people and what they're entitled to. 47% of pediatricians in a survey in 2008 assist with a referral to family or internal medicine. That's less than half of us, albeit at the last time the Academy of Pediatrics surveyed this. Only 32% assist with finding a primary care physician. Less than half refer to adult specialists, and a third discuss consent and confidentiality issues prior to age 18, when as of age 18, as you know, that person, unless some other arrangements have been made, is a legal adult and owns their health care information, and no one else can have access to it without consent. It takes some time sometimes to plan that. Family medicine, internal medicine MDs tell us that new young adult patients arrive without medical records. In fact, no one has coordinated this handoff. It's a transition of care, like kids going home from the hospital and back to the community. And it's a very vulnerable moment. And generally in this country, we haven't done a good job of communicating what's in store. And they have usually a limited understanding of the child's condition, and the child has, or the young adult, has little or no experience navigating the adult healthcare system. Lack of payments for transition services, like the pediatricians. They also have limited knowledge of childhood onset conditions. I think this is a huge issue that I think it's going to be difficult, frankly, for us to address, because we're not going to have internal medicine residencies suddenly spending enough time to understand the large number of chronic conditions of childhood onset. I mean, they'll understand asthma and diabetes fine, but when you get to metabolic disorders and unusual genetic conditions and cystic fibrosis and even sickle cell disease, they're not getting that kind of training. And I don't know that we're going to be able to turn that around, given all of the training requirements that adult providers have about the other end of the age spectrum, about the chronic conditions of later adulthood. And you know, those are the costly elements of our healthcare system, and the ones that policymakers and training supervisors are interested in affecting. And they have a lack of understanding that the life course transition that this young adult is experiencing doesn't end when they walk out of the pediatric practice. It's an ongoing process through the 20s. Some of us in developmental pediatrics are saying, well, adolescent ends at age 29, and we have neuroscience to prove that. The fact is that they're not done with this transition when the handoff occurs. And we have to help adult providers understand this from a developmental standpoint. So this is some internal medicine nephrologists that Maria Ferris surveyed. She's a nephrologist and a parent in North Carolina. And she asked these adult nephrologists about newly transitioned patients with chronic kidney disease and kind of what their impressions were about them. They said about 45% of them knew what medications they were on. And 30% knew what disease they had. and 20% of them asked questions during the office encounter. And it appears that most of those, or many of them, were going to this adult office encounter with their parents still, and 70% of the questions were asked by the parents. So there's obviously some preparation. This is one of the starting early concepts, is that it isn't just about providing, an adult provider and making the handoff. It's about, has this person ever filled a prescription? Has this person ever made an appointment for themselves with a healthcare provider? Do they know what their medications are and what the side effects might be and why they're taking them? Do they know the name of their disease and something about it? And some of this education needs to be going on in adolescence before the transition occurs. We surveyed adult primary care providers in New Hampshire, and I'll just kind of skip to the chase, so to speak. They were more comfortable with asthma, hypertension, mental health issues, and diabetes. Not surprisingly, that happens across the adult spectrum. Less so with CF, metabolic disorders, autism, technology-dependent young adults. Almost 100% said a written summary would be helpful. And 90% wanted to speak with the pediatric provider. There needs to be an ongoing relationship for months or maybe years between kind of a reverse consultation for adult providers to be comfortable. We as pediatricians can help them be more comfortable. We know the diseases. We know the kid. We know what's happened for 20 years or 18 years. That adult provider needs to have access to what we know and a mechanism for providing that. I mentioned the majority of existing transition programs are tertiary based, often in specialty clinics or limited to a subset of youth with complex needs. This is not a bad thing to do, and particularly for those complex needs situations. And it's important in terms of the training mission that most of those tertiary-based centers have, so that pediatricians in their training programs, and maybe some rotating med peds and even adult medicine docs, can learn something about the transition issue. We have very little evidence about what characterizes an effective transition intervention. How do we know when we've done a good job with this? What kinds of outcomes are we looking for? And there are people working on this. I'm not an outcomes researcher in a strict sense, but it has gotten on the radar of NIH and the Maternal and Child Health Bureau and some payers, so that we're looking for what is a successful transition? What does it look like? Is it about the length of time between the last pediatric appointment and the first adult appointment? Is it about the satisfaction of the young adult with that first appointment? Is it about health outcomes, if we have indicators to look at that? We need more outcome data, especially if we're going to ask somebody to pay for this transition process and the time that it takes. We've got to prove that it really does help. It's intuitively obvious that it would help to plan and have warm handshakes instead of handoffs and so on. But the majority of pediatric and adult care providers are in separate systems, and they have limited interaction with one another. When I was a primary care pediatrician in Newport, New Hampshire in the late 1970s, we covered the emergency room and took care of all of the this is a small town. It was a 23-bed hospital. I was the chairman of the pediatrics department, with two, and the only member. But we saw each other every day. We made rounds on our patients every day. And I know there are larger scale examples of this in those years that were like that. There were no hospitalists. There were no ER physicians. And that's all changed. And except for maybe newborn care, there are many settings where neither pediatricians nor adult community primary care providers go to the hospital at all, except for some meetings once in a while. and their meetings may be separate. So they don't have collegial relationships that they might have had 20 or 30 years ago. And believe me, some of the solution to where's the adult providers is going to be about relationships. It's not, it's going to take some work along those lines. There's limited widespread awareness of the problem of pediatric to adult healthcare transitions. I'm so pleased that this room is so full because I think this awareness is growing, but it's new, and it's certainly still mostly in the pediatric space and not in the adult space. Are there health outcomes associated with health? Does it matter whether transition goes poorly or not? Are there consequences that are health problems? Well, take a look at sickle cell disease. Some of you may be familiar with this. It's not new information, but we've had several decades of unbelievable improvements in morbidity and mortality for children with sickle cell disease. From birth to age 18, the mortality rate and the hospitals, everything has dropped as a result of enhancements in care and I think the quality of care that they've received. But if you look at the next age cohort from 18 to 35, there's a dramatic and almost immediate increase in rehospitalization rates for this group. And there's increased mortality that's not huge, but significant and noticeable, and it stands out in the data. And it often occurs within 1 to 2 years of the transition to adult care. Well, maybe sickle cell disease suddenly gets much worse in young adulthood. I mean, the disease may become more difficult to manage, but I can't help but feel that some of this has to do with people drifting into the netherworld and not, getting the care they need. HIV, there's a decline in CD4 levels, declining adherence to therapeutic regimen after the transition to adult care. Childhood cancers, you all know how the story about childhood cancer has changed over the last generation, and more survivors reaching adulthood. But they survive with long-term risks. They have higher mortality, health complications, et cetera. Less than 50% of adult survivors of childhood cancer have had any cancer-related follow-up in the previous 2 years of a study. They also disappear from a sort of comprehensive healthcare system. So those are, I think, outcomes that we would rather see avoided, and I'm sure there are others. But we rely on this process taking place in a kind of a netherworld of it'll work out, it'll happen. They leave pediatric care kind of gradually or just disappear from our roles. We haven't seen them in a couple of years. They go off to military service, they go off to college, they go off to a lot of things that, pull them apart, but they don't reconnect with adult care. And if they have a chronic condition, they need to have done that. So there is help on the way. In addition to those 4 buses of adult providers, I would really encourage you to find and read the Healthcare Transition Clinical Report. And read it critically. It may not all suit you, but it has an algorithm for what should go on from age 12 into the early 20s. It has a little bit, albeit less than I would have liked, about what happens on the adult side of that bridge, quite a lot more about what might happen on the pediatric side. And take a look at gottransition.org. Any of you familiar with our website? A few hands. It's a Maternal and Child Health Bureau funded project, like your medical home implementation project, I think. We began it, and it was a continuation of National Centers on Healthcare Transition that began, 15 years ago at least, with Healthy and Ready to Work was the sort of brand name for a while. We got this grant in 2010 and adopted the brand name of God Transition and characterized the work as creating the tool set that healthcare providers needed, pediatric and adult healthcare, to do a better job with transition. And it's now under new leadership, thankfully, as far as I'm concerned, not wanting to manage or be the PI, but loving the work. Patience White and Peg McManus at the National Alliance for the Advancement of Adolescent Health in Washington are now the PIs and continuing this effort using some of the same models and thinking of it as a, how to grow up sort of guide. Just briefly, the clinical report mentioned it was published in 2011. It was jointly endorsed by the AAP, the AAFP, and the ACP. So all three of these organizations consider this to be best practice as far as healthcare transition is concerned. It's not to say that's created a revolution on the adult side, but it at least has provided some credibility for this issue. It provides practice-based guidance, step-by-step algorithm, and integrates transition planning into the broader medical home model that you all have been working on here in Tennessee. And there's the reference. It targets all youth. It isn't just about special health care needs. It's about all three of my kids, beginning at age 12. It's not to say you kick them out of your practice at age 12 or even imply that you're going to, but you begin to introduce the concept at an early age. And algorithmic structure and it extends through the reports extends through the transfer of care to adult providers. And it's an explicit template for planning and decision-making and documentation processes. So it's really something to look at. This part about starting at age 12, a lot of pediatricians feel uncomfortable with this. They say it's going to make families think that they are throwing them out. I think it's a matter of how you present it. But what's asked for in this report at age 12 is that youth and families are made aware of your healthcare transition, your practice's healthcare transition and transfer policy. Now that implies one thing, that you have a transition policy. Anybody have a written policy for transition in their practice? I see a few hands. And that healthcare transition planning might begin a few years later. And it can begin on a very small scale. Does this person want an adult female or male provider? Does the family already have adult health care that would be a useful place to go? And is that the direction they want to consider? Just some initial ideas. It creates a space in the medical record for transition planning that will be amplified as the following years go on. Transition at age 18, which is sometimes when we think this handoff might occur, whether or not the handoff occurs. I mean, family physicians and audiences that I've talked to often will say, well, we don't have to worry about this. We take care of people across the lifespan. There is no transition. Well, let me tell you, transition is, what we do is transfer care. What the youth does is transition to becoming an adult. We aren't transitioning anybody, really. We are watching a transition unfold. And in a family medicine practice, when this youth turns 18, they're an adult, and they need to be treated like an adult. And in my view, it doesn't matter if they have an intellectual disability or complex health care needs. They need to be treated like an adult. And how that is done is something for some thoughtful quality improvement process in an adult practice. So that's what happens at age 18 in this clinical report. Not necessarily the handoff of care, but the transition. So pediatricians need to know how to treat their patients as adults. In a legal sense, even if you're in a pediatric practice, if you haven't gotten consent to give that mom or dad health information and the kid has turned 18, your front desk should be saying, I'm sorry, I can't tell you the lab results. You need to get signed consent from your 18-year-old daughter. 18 to 22, the report says the transfer of care to adult medical home and specialists without, et cetera. We didn't pin down the age because we knew that there was going to be a range. And there's maybe a broader range than 18 to 22. Part of this report says it's going to have to be individualized to different localities and different individual patients and so on. It isn't hard and fast law that it has to happen. But the first step is the transition policy. And if you go home to your practices and do anything at all next week, it would be to sit down with your staff and say, what's our transition policy? What should it look like? What should it say? How do we communicate it to one another on the staff? I mean, if you have several providers in your office and somebody calls the receptionist and says, well, how old do you take patients? You know, what's the age, the upper age limit for your practice? It's likely the receptionist will say, well, Dr. So-and-so kind of has everybody leave at age 18, but Dr. Smith really likes to hold on to her patients, and some of them are in their late 20s, and you know, or they'll just simply say, well, I don't know. So it helps to have that, and it helps to make patients familiar with it. And one of the reasons to have a policy is to ensure everybody's on the same page and to ensure that there's a mutual understanding of the processes involved. And to provide a structure to look at how well you do things you say you're going to do. You can't really evaluate your success with this issue of transition unless you've set the rules for yourself through a policy. We aim to do this in this way, and let's take a look, by the way, in a few years at how well we're accomplishing that. So when we started Got Transition, we decided that we would use the clinical report as a grounding and that we would try to translate its information into 6 easy steps. I put easy in quotes, but to make it not a vague and not a kind of 20-step process. So we felt that if people could handle these 6 steps or work on them, either sequentially or simultaneously or gradually or through quality improvement or whatever, that they would have gone a long way towards improving transition. We developed, some of you may be familiar with the Medical Home Index that we developed at the Center for Medical Home Improvement. We used that design to develop something we called the Healthcare Transition Index. And it was a measure, a scoring system based on these 6 core elements that I'll introduce you. And here they are. And there were 6 core elements with a pediatric setting in mind, and the same 6 core elements translated somewhat into the adult setting. And the first one is having a healthcare transition policy. And when we worked in a quality improvement model with this learning collaborative model, we worked through these from 1 to 6. Transitioning youth registry, knowing who the transitioning youth are in your practice. Who are the people in this age group that you're taking care of? Maybe stratify that if some of them are very complex compared to some who are not. A transition preparation process, skills checklist, a portable medical summary that those adult providers say they would really like to have, a 2-pager that says who's been involved and what some of the issues have been. A transition planning process. This is basically a care plan for a child without special health care needs that maybe only have 1 or 2 lines on it about who the adult provider is going to be and when the transition date is going to occur. A transition and transfer of care, that's the handoff. That's when you actually do this passing off of care and what goes with that. And finally, transition completion. When do you say you're done? It isn't when they walk out the door from their last appointment, by the way. And there's some principles in transition of care literature, particularly the adult literature about transitions from the hospital to home or to a nursing facility or whatever. And that is that the sending facility, the sending provider, is still responsible for care until the receiving provider has actually taken up the care. It might be 3 months before that person can get an appointment with an adult provider. Who's going to fill the prescriptions during that time? How do you make that clear? Well, it's going to be you. It's going to be pediatrics that's responsible until there's actually been an appointment and been an uptake of care on the adult side. That's one of the big sort of potholes that somebody could fall into very easily. We ran learning collaboratives, and I'll go through this kind of quickly, but we tested this model in a number of sites with a fairly large number of practices between 2011 and 2013. And this is the DC Learning Collaborative, some of the teams that met and then tried to carry this out. They had good results. In using DC as an example, substantial improvements in both the adult and pediatric practices. There were both kinds involved. All the practices had policies. They all developed a method for identifying and tracking transitioning youth, a registry. All sites conducted transition readiness assessments. At the end of the collaborative, there were close to 500 youth who had readiness assessments done, transition plans for about a third of transitioning youth. And in the course of this collaborative, about 50 youth were transferred into adult practices. One of the striking things as you go down this list is the shrinking numbers as you get towards the bottom, towards the hard part. One of the things we learned was that there was a tendency for these pediatric practices to want to transfer the patients with the most pent-up need. So they were handing off their most complex patients who are going to be the most difficult instead of trying it out with some easier patients. These were their healthcare transition index scores at the beginning in blue and at sort of midway in red and then in yellow at the end. And they all showed improvement across the board. Sometimes they drop off a little bit because these are self-assessments and people assess themselves more critically as time goes on in a project like this. Lessons learned, forming partnerships between pediatric and adult practice teams at the beginning is essential. This is a relationship and it needs to be there. For this to work in any setting, thinking about cultivating those relationships is going to be important. Transition planning in early adolescence is much easier than transition planning at age 21. Start early. It just was clear. This is from focus groups of these practices giving us feedback about what they'd learned. So involvement of nursing, social work, care coordination staff, engagement of consumers is really important. All of these quality improvement teams had a young adult who'd been through this process on the team. And some of them had a family, a parent as well. Availability of tools that can be adapted easily. They wanted to know what a transition plan looked like. So we gave them sample plans, but told them to tune it up, modify it, change it. There's a real requirement of pediatric and adult clinical leadership. If you're in an organization that has senior leaders, they need to say this is a priority for us, or things just will stagnate and not move on. Electronic health record integration, this has been challenging, as you know, for reasons that I'm sure you're familiar with, the variety of products that are out there and so on. It just is hard for people. It's not a priority for IT staff in a lot of settings, so it's hard to get the attention that's needed. And of course, payment mechanisms changing. This is almost the last slide, healthcare transition has been seen primarily from the pediatric perspective, and the adult role is unclear at first. Our adult providers in these learning collaboratives thought that they were just waiting for the handoff. They didn't think they had anything to do. And then they realized, gee, I've got a lot of 20-somethings in my practice already. How well am I taking care of them? So they began to look at 20-somethings as a special population that was previously unrecognized. They treated a new patient, a new 25-year-old patient in the practice, coming into the practice, in the same way as they treated a 45 or 50-year-old patient. Same intake, the same process, not recognizing that this person was completely new to the adult healthcare system, and for whom health and healthcare were not a high priority necessarily, and who were unready to be managing their own healthcare. And medical home functionalities, the practices we worked with that were already through a process of medical home improvement were much more ready to take this on than practices that hadn't touched medical home functionalities. The Center for Healthcare Transition Improvement is continuing, as I mentioned. We're continuing to use the 6 core elements. They've been updated and improved There's some new measures that you can take advantage of. We're trying to work with some large integrated health systems to see if we can develop some data about outcomes. So Kaiser of Northern California, Health Partners in Minnesota, the Uniformed Health Services, Pediatric Hematology Clinic. So we'll be able to look at settings with a single health record. So if you're going to get started on this, and I hope you are here because you plan to, if you haven't already, engage those senior leaders right away. Develop transition policies. There's almost no point in trying anything else until you have a written policy. What are you aiming to do, and how will you know you've done it? Forge relationships with adult providers. Take an internist to dinner. I don't know. It really is something that like that settings that have been successful have done. Engage parents, youth, and young adults to inform your efforts. Really important. And launch a healthcare transition quality improvement agenda in the practices and clinics.